So let's switch gears to MIGS. MIGS, of course, has exploded on the scene. Lots of options out there. Just briefly, what MIGS are you using and where are you using MIGS?
So I'm one of those proponents that every device, every procedure has its place. And so I routinely, in any one OR day, tend to have several procedures on that OR day. And I try to evaluate the patient and try to find the best procedure that fits the patient's pathology in the eye, fits the patient's level of medication. And I use it anywhere from mild to severe. And I try to utilize MIGS prior to doing any filtering procedure.
Well said. I agree. I think the key is that we're now able to titrate and actually customize our devices and our procedures for the right patient. And it's kind of like in premium lenses. Same principle now in glaucoma. We never had that ability until now. But I think that's the key issue, is that which patient needs what device, and that's where I think it just depends on each situation.
And what percentage of your practice is combination cataract MIGS versus MIGS standalone, and how do you use devices in that space, in those different spaces?
So I'm about maybe 60-40 or 70-30, more towards heavy combined surgery. So I definitely want to take that advantage of a patient with visually significant cataracts who's on multiple drops and go ahead and treat them with a MIGS surgery to try to bring their eye pressure down. I think that's a great time to capture them. And quality of life-wise, we don't have to talk much about that, right? Yeah.
It's gone down from, it used to be probably 90% cataract MIGS and then 10% standalone, but I think with all the new products available, kind of like ABIC eye track and others, having the ability to do a standalone procedure has really allowed myself to go back, and especially the pseudophakic patients who are just not tolerating medications. They're kind of stable on their fields and nerves, but they're just not happy. And that's the kind of patient now with all these devices. I'm like, you know what, why not just go in there and get rid of the drop burden? So that level, that ratio has actually changed now to probably like 60-40 now.
So let's focus on one of the MIGS, ab-internal canaloplasty, using eye track or ABIC eye track. We've all used the system. I think there's emerging and increasing interest in ab-internal canaloplasty and eye track. Could one of you or a couple of you maybe describe how ABIC works and what the mechanism of action is and how it lowers pressure?
The way I describe it to my patients is that it's essentially angioplasty for the eye. Right? You're taking a drainage system that's been stopped up, you're expanding it and rejuvenating the natural outflow. And patients get that because they all understand what angioplasty is. And one of the things that I like about eye track ABIC, we were talking about just a few moments ago, the kind of how we approach it. I approach MIGS from a very stepwise approach. I first want to, using SLT, get the trabecular meshwork working better. If the trabecular meshwork improvement is not enough, then I want to expand and make sure that the outflow system is truly open through eye track ABIC. And then the next step I see is placing a stent, so creating a communication pathway. So that's kind of the stepwise approach that I take. And patients understand that it's you've got obstruction outflow, you've got a drainage system behind that, and then sometimes you have to open it up. And so that, it's nice because it's a very simple, straightforward, easily understood discussion to have.
So like you mentioned, truly the epitome of interventional therapy here, interventional glaucoma therapy. So you asked about the mechanism. I think what we're doing here is viscodilating Schlemm's canal that might have herniated TM in it or a collapsed canal. But we're viscodilating so much that I think we're creating intratrabecular fractures and beams there. So a lot of folks have a misconception that it's only working on canal distally. I think it comprehensively treats everything. And so that's why it's my first go-to MIGS, because I don't know where the obstruction is. I don't know where the level of resistance is. I don't have that diagnostic to tell me where it's at. And then I like to start off with that. And the other thing is, it doesn't burn my bridges. I can do anything else afterwards. It's not destructive. I don't have to worry about a device. There's a lot of things out there that's that are pretty revolutionary, but I like to start off with this first.
And we were talking earlier about SLT being a diagnostic device. Well, if eye track ABIC doesn't work, there's no point in going in later and putting a stent in or a scaffold, because the eye track ABIC is telling you the system's not capable of being reopened. Now, fortunately, that's quite rare. But if we're looking at a stepwise approach, that would be a patient who does not respond to eye track ABIC is somebody that I would not then place a stent in, I would instead look at a suprachoroidal shunt or
Subconjunctival or something
Yeah,
like
something
that.
like that. Mhm.
Could you explain that phrase, trabecular herniation? I just learned about this.
When you have when pressure is increased and then you have TM herniating into Schlemm's canal, Dr. Gong out of Boston has put a lot of beautiful path slides showing us POAG patients compared to normal patients, and POAG patients tend to have a lot more herniations and a lot more complete herniations. So in other words, I just basically tell my patients that, you know, your canal looks like this when it's working normally, but if it's clogged up or it's collapsed, we're just going to balloon that open. And so that's kind of what I'm talking about there.
Yeah.
And she found that 90% of collector channels are actually obstructed by these herniations. When she did her path work, she sectioned post-mortem POAG eyes at 0 millimeters of mercury, and still 90% of those collector channels were obstructed, as opposed to just 10 to 15% in non-POAG eyes. So the eye-track catheter itself lyses these herniations within the canal, in addition to viscodilating the distal system. But Robert Stegman also showed that we create these microperforations within the inner wall of Schlemm's canal. And we know we have these inter and intracellular micropores that allows aqueous to enter Schlemm's canal itself, because endothelial cells are connected by tight junctions. But the population of these pores actually decrease in patients with POAG over time. And so by viscodilating, we're essentially creating more of these micropores so that aqueous can actually get into the canal.